Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Dr. Shabana Mukhtar Laku, for inviting me to the lecture. First of all, let me congratulate Professor Javed Akram Bhai, Professor Aftab Mohsen Bhai, and Dr. Somya Iqtidar Bahan for launching Sakar chapter and now Larkana chapter of Pakistan Society of Internal Medicine, PSIM. What a great initiative in contribution towards the noble cause and uplifting of patients' care in our country and bringing it at par with global standards. Jazakallah khair. I am extremely thankful to Professor Hakim Ali Sahib, Professor Bashir Ahmed Sheikh Sahib, and Dr. Ali Haider Bhai for their kind invitation to this symposium. I have been many times to Larkana and have always received very warm welcome and extreme love here. Thank you, Larkana, for being so much generous every time. Unfortunately, I could not come because of some health issues, but I am sure today's symposium will be an unprecedented event in the history of Larkana, and there is no doubt in it when top leadership of the country is around and involved in its execution. So let's start today's lecture. Bismillahirrahmanirrahim. Dear chairpersons and co-speakers, topic allocated to me is update on management of chronic hepatitis B. In the next 20 minutes or so, the focus areas for my discussion will be to know that hepatitis B is a major global health problem. We'll briefly see the hepatitis B virion and its markers, the natural history of hepatitis B and its cure, then antiviral treatment, when to start and when to stop, current and future antiviral treatment options. We'll briefly compare the previous and the new guidelines on treatment for hepatitis B. And at the end, I'll share with you the hybrid algorithm, which is based on the latest guidelines, Chinese and WHO guidelines. Hepatitis B is a major global health problem. According to WHO report 2019, worldwide prevalence of hepatitis B was 3.8%. with 1.5 million new cases every year and 0.8 million deaths due to HBV-related liver failure cirrhosis or HCC. The hepatitis B virus pool was comprising 296 million cases, and out of these 296 million cases, 88% they resided in Africa, Southeast Asia, and Western Pacific region. And dilemma was that only 10% of these 296 million were diagnosed and merely 2% treated. Countries most affected by hepatitis B, Pakistan is among these with the prevalence of 2 to 4%. These are the WHO 2030 targets that by 2030 there should be reduction of 65% in the deaths because of hepatitis B and C and 90% reduction in the new infection. This was the situation in 2030. We are here now in 2025 and you can imagine what a big challenge it is for us. For my younger colleagues, medical students, house officers, and PGs, this is the hepatitis B virion, and we know it has got different components. The surface antigen, which comprises three types of proteins: the large surface proteins, the medium surface proteins, and the small surface proteins. Then the E antigen, then the core antigen, and of course the DNA and the DNA polymerase. The current markers which we check in our clinical practice, these are the HBs antigen by ELISA, HBe antigen by ELISA, and the HBV DNA quantitative PCR. The antibodies we check, these are the antibodies to HBs, antibodies to HBe antigen, and then antibodies to core antigen, these are IgM and total. The novel markers which will be hopefully available to us in the near future, these include quantification of HBV RNA. What we are doing today is the quantification of HBV DNA. This is the HBV RNA quantification, the HB core related antigen detection in the clinical practice, and quantification of anti-HBC antibodies. And what's their clinical significance? It's threefold. In the diagnosis, they help to diagnose HBV infection, particularly in patients with unclear or negative HBV serological markers. Then they have got significance in monitoring of the disease to monitor the effectiveness of antiviral therapy in patients with chronic HBV infection. And of course, regarding the prognosis, the high levels of these are associated with a higher risk of liver damage and hepatocellular carcinoma. So with the help of these novel markers, we will be able to tailor the treatment to go for the precise medical options for hepatitis B virus disease patients. Few words about the HBV. We know it's a lifelong disease. Once HBV infection, when it appears as acute hepatitis B, it is characterized by the positive PCR, HBs antigen positivity, and the nucleus containing the cccDNA. Within 6 months, and most of the times, this recovers, and this is called functional cure. By functional cure, I mean the PCR becomes negative, the HBs antigen becomes negative, but still the cccDNA remains positive, and this remains positive lifelong. Most of the times, the HBV infection, either through the acute hepatitis B or without being noticed as acute hepatitis B, it follows the chronic hepatitis B track. And this phase lasts for more than 6 months, for years, even for decades. And at times, spontaneously or mostly with the help of the drugs, it may go into a partial cure phase. And what do I mean by partial cure phase? That the DNA PCR becomes negative, but still HBs antigen is positive and cccDNA is positive. And from the partial cure, the next phase is the functional cure when the patient loses HBs antigen, but this is dream for most of the patients. Another point is, if a patient has spontaneously gone into functional cure, there is a risk that this patient may get reactivated and the HBs antigen may become positive, and now this will be a partial cure stage. There's another cure, and that is the complete cure. And by complete cure, I mean when the patient loses HBs antigen, the PCR becomes negative, and also the cccDNA becomes negative. And we all know that the damage received by the liver is during the chronic hepatitis B phase, when to start with there is liver without fibrosis, then the fibrosis starts depositing, and the from F1, F2, and F3, and then when there is F4 level fibrosis, there are regenerative nodules, and F4 fibrosis plus regenerative nodules is equal to cirrhosis. So if I summarize the cure of hepatitis B, we know that the partial cure means when the PCR becomes negative, HbS is still positive, and cccDNA is positive, and this is what the current available treatment gives us. The functional cure, mostly this is spontaneous, but at times the drugs may give you the functional cure, but the complete cure will where all these three parameters will be negative. This is the hope for the future antiviral treatment. Currently, this has not been possible with the available treatment options. Now, a few words about the antiviral therapy. The current therapies algorithm in 1992, interferon, they were recommended. In 1998, the new era of the oral therapy started with the discovery of the lamivudine. Then in 2002, Adifovir came into the market. In 2005, entecavir and pegylated interferon, they were introduced. Entecavir is still the treatment of choice in current scenario. And when the patient has got hepatitis D co-infection, then we go for the pegylated interferon. In 2006, telbivudine came, but it did not sustain. Then in 2008, the tenofovir TDF, it was marketed, and still this is the drug of choice. And in 2016, November, tenofovir alafenamide, it came, and now the available treatment options, these are the TAF, TDF, and entecavir. What about the future? A few words. When we get a new drug, this is appears to the regulatory approval, and it takes 1 to 2 years. But to get this one new drug, we need at least 5 compounds to undergo the phase 1, phase 2, phase 3 clinical trial, and the total duration required is 6 to 7 years. And for these 5 compounds to undergo the clinical trials, we need at least 250 compounds, which should be checked in preclinical studies in the in vitro and in vivo toxicity and pharmacokinetics, pharmacodynamics, and this takes 1 to 2 years. And to select these 250 compounds, really you need 5,000 to 10,000 compounds to undergo the different research protocols, the target identification, validation, assay development, lead generation, and this is 3 to 5 years duration. So by and large, to get one new drug for the clinical practice, we need a huge research of 5 to 10,000 compounds going through these different phases, and the total duration is 10 to 15 years. So what are the drugs in the pipeline? Replication inhibition, the entry inhibitors. Probably this is going to be the first drug available to us for the hepatitis B, the entry inhibitor in hepatitis D. It is being recommended, but for hepatitis B, this will be hopefully the first one. Then the HBV polymerase and nucleocapsidases. Then the another group, the antigen reduction, so many molecules. These are being studied for immune stimulation. Again, the immune checkpoints inhibitors and the innate immunity interventions. Then, of course, to stimulate these HBV-specific B T cells, the therapeutic vaccine, and of course, the monoclonal antibodies. So, huge number of drugs they are in the pipeline, and hopefully, in the coming years, we'll be getting many drugs, and these will be directly acting antiviral drugs, just like the DAs for hepatitis C, and we will be hopefully able to clear the hepatocytes nucleus from the cccDNA and just cure the hepatitis B viral disease. So, dear colleagues, as I said, that the current treatment is just giving us the partial cure. The functional cure has not been, the complete cure has not been the power of the current available therapies. That's the reason what we see plethora of the guidelines, because each and every patient was not a candidate for treatment, and over last so many years, almost every year we used to get guidelines from the SSLD or the EASL or a PASL or WHO, and these last two guidelines in 2020-23 by Chinese and 2024 by the WHO, they have really caused the paradigm shift of 180-degree in an attempt to achieve the 2030 target of hepatitis elimination from the world by the Chinese and the WHO target is 2030, and this is how to achieve it. In 2030 we got these guidelines. In 2024 the WHO guidelines, the Chinese guidelines. What they suggest that when a patient is found to be having HBs antigen positive, look for the causes when there is need to prevent the reactivation. If yes, treat. If not, do the PCR. And what they are suggesting, the qualitative PCR, if it is detected ALT is raised, treat. If it is detected ALT is normal, go for these few peculiar situations. If these are present, treat. Otherwise, you just follow up these patients. The WHO has given 4 scenarios. The first scenario is when there is fibrotic or cirrhotic liver, you treat these patients irrespective of the DNA levels and ALT levels. So practically no PCR required here. When the DNA level is more than 2000, ALT is raised, to treat these patients. And third is when there is presence of specific conditions like co-infection, family history, comorbidities, or extrahepatic infestation, you treat this patient even with negative PCR. And the fourth is very interesting, that when there is persistently abnormal ALT levels and the DNA cannot be checked, so even with the negative PCR, presumably if it is, you treat these patients. If I convert these 4 options to compare with the Chinese, it becomes like this, that there are few peculiar situations where you want to prevent the reactivation of the hepatitis B virus from the functional cure to the partial cure, then you treat these patients. Otherwise, you do the PCR. The WHO is recommending the viral load estimation, more than 2000 ALT raised, treat. More than 2000 ALT normal, it's quite here. Less than 2000 ALT normal, you just follow up these patients. Less than 2000 ALT persistently raised, you treat this patient. So, to compare the old versus the new treatment algorithms, depending upon the liver status, the past guidelines, the EASL, the APASL, the SSLD, what they required, the PCR should be detected. But now the Chinese and the WHO guidelines, PCR is not required to start the antiviral treatment. And this is the red strip. The yellow strip is patients with fibrotic liver. The Chinese says PCR needs to be detected. The WHO says PCR not required. But the previous guidelines, they were requiring viral load to be more than 2000 and ALT to be raised. We see a huge difference in the patients where there is insignificant fibrosis. In the previous guidelines, the treatment option depended upon whether the patient was in immune tolerant phase, immune reactive phase, immune control phase, or immune escape phase. And depending upon these, the treatment options were given. But the Chinese guidelines, they've simplified whether PCR positive or negative. When the PCR is positive, ALT is raised, and then treat this patient with insignificant fibrosis. And the WHO says that the PCR should be positive and it should be more than 2000. When it is more than 2000 ALT raised, treat. Otherwise, you don't treat these patients. And so it brings me to a question that when to start antiviral treatment. I already discussed this diagram with you. So the first option is to prevent reactivation of hepatitis B virus infection. When there is a risk that the patient may get reactivated from functional cure to partial cure, then you start these patients on treatment. The second indication is depending upon the disease. When disease, you want to control the hepatitis B virus, then depending upon whether the patient has got insignificant fibrosis, significant fibrosis, or cirrhosis, you give these patients treatment. Once you start the patient on treatment, when to stop it? This is another very important question. 2 treatment scenarios. If the treatment was started to prevent reactivation of hepatitis B infection, practically this is a lifelong treatment or till the risk of reactivation exists. But if you had started the treatment to control the hepatitis B infection, then stopping the treatment depends upon type of the therapy and liver status. And in the liver status, whether this is cirrhotic, fibrotic, or normal. What do I mean by this? Let's explain to you. I started the patient to control hepatitis B infection. As I said, when to stop antiviral treatment depends upon type of therapy and liver status. If I had started the patient on pegylated interferon, there's defined duration of 48 weeks, and I will stop this patient's pegylated interferon irrespective of the treatment after the 48 weeks. But if I had started the patient with oral therapy, then the end point depends upon the hepatic and HBe antigen status. If my patient liver was cirrhotic, lifelong treatment is mandatory. If my patient liver was fibrotic, again, lifelong treatment is mandatory. This is only when my patient's liver was normal with insignificant fibrosis, then depending upon the HBe antigen status positive or negative, I can stop. In HBe antigen positive patients with normal liver, I can stop treatment in those who achieve stable HBe antigen seroconversion and undetectable HBV DNA and complete more than 12 months of consolidation therapy. And in normal liver and EHB antigen negative, I can stop the patient treatment in those who achieve long-term, more than 3 years viral suppression on treatment. But remember, in this group, close monitoring for reactivation is warranted. So this is how to stop, when to start treatment and when to stop antiviral treatment. Okay, to get the best of the guidelines, you really need to be among the wise people. You need the consultation with the wise people. And what they say, that clinical guidelines, these are the tools of management. So we need to see the clinical guidelines to see if my patient needs antiviral treatment or not. But another wise person has come, my daughter. And what did she say to me? Abu, clinical guidelines, these are tools of management, not rules of management. Let's see. What does it mean? Depending upon the latest two guidelines, the Chinese and WHO, let's make an algorithm. When a patient comes to me with HBs antigen positive, but I need to check for the co-infections, hepatitis D, HCV, and HIV. These are negative, suppose. Then two types of medications are there, we learned, either to prevent reactivation of hepatitis B or to control hepatitis B infection. Coming to the first scenario, and in accordance with the Chinese and WHO guidelines, I will look for these 6 scenarios. Whether the patient needs to prevent reactivation of HBV infection, like if my patient is going to receive chemotherapy, targeted therapy, immune therapy, or liver transplant. If my patient has got extrahepatic manifestation, if my patient has got co-infection with HIV, if there is a family history of liver cancer or cirrhosis, and if there is comorbidities like diabetes or MASLD, or if my patient's liver status is cirrhotic or having significant fibrosis, or the patient has got HCC or liver failure. If my patient has any one of these 6 scenarios, then these options come into play to prevent reactivation of hepatitis B infection. So if my patient is falling in one of these 6 scenarios, I will start my patient on antiviral treatment. And this will remain lifelong until the risk of reactivation exists. If my patient is not having these 6 peculiar scenarios, then I will go for the PCR. Chinese says qualitative PCR, WHO says quantitative PCR. Just I need your attention over here for a minute. This is the revealed data from Taiwan, very old study of 2006-2005, and what they recommended and what they found that of course viral load more than 2000 has got the maximum association with the cumulative risk of HCC and liver cirrhosis. But what about those where the viral load is less than that, than 2000 and less than 60? Even then, there was a risk of good risk for cirrhosis and cumulative incidence for HCC at the 10 years follow-up. So even lesser amount of viral load is not safe. Another study, the old one in 2010, and what did they? The authors found that when the patient has got a positive PCR, the risk of cirrhosis is 6% and HCC is 12-fold. But of course, it depends upon the viral load. Higher viral load, the risk is significant, but even less than 2000, this is not without the risk. So to me personally, the numbers, they are important not to start the treatment, but they are important to follow up these patients. So irrespective of the viral load, I'll start the patient on treatment, but if my patient's PCR is negative, then comes the ALT levels. And the WHO says the normal ALT level for male 30 and for female 19. And according to the WHO option number 4, if my patient's PCR is negative but the ALT is persistently raised, then I will consider my patient for antiviral treatment. This is when the PCR is negative, ALT is persistently normal. Then the two risk factors I will take into consideration. One is age more than 30 years. Second, if there is co-infection with hepatitis C or hepatitis D. And these are very much covered by the Chinese and the WHO guidelines. So if my patient age is more than 30, I will start the patient on treatment even with the negative PCR and a normal ALT. And if my patient has got co-infection hepatitis C and D, during that treatment for hepatitis C and D, I will cover the patients. I will give the patient my patient hepatitis B treatment as well. This is only when the PCR is negative, ALT is normal, no these situations are there, then of course 6 to 12 monthly follow-ups will be required for my patient. So this is how I'm simplifying the treatment algorithm to start my patients on antiviral treatment depending upon the Chinese guidelines as well as options given by the WHO guidelines. And that's the reason I call this hybrid treatment algorithm by me. So, dear colleagues, I think I have tried to simplify it for you, the algorithm, and I hope you will agree I have been successful in that. So, this really qualifies me for a special coffee. So, those who wants to get this lecture and slides, you can log on to my YouTube channel. You can scan this and you can get this lecture along with the other lectures. By this, I end here, and I once again pay thanks to the organizers and Pakistan Society of Internal Medicine to invite me to this symposium. Once again, I'm very sorry I couldn't make it physical, but I hope inshallah in the coming timings we'll be again together. Thank you very much. God bless you. Khuda Hafiz.